All right, I think we're going to go ahead and get started. So good afternoon to everybody who is joining us, both Leadership Winston-Salem alumni and friends of alumni. My name is Catherine Perry. I'm the Executive Director of Leadership Winston-Salem, and I'm delighted to have you here today for our Innovations in Healthcare Leaders in Lunch. Leaders in Lunch series happens every month as a way to keep our alumni engaged and connected to all the new and wonderful things happening in our community. I did want to let everybody know that we are entering our recruitment stage for our flagship program. So if you or someone you know would love to be a part of our flagship family, I would like to encourage you to click on the link that Jared is now going to enter into the chat and nominate a candidate for next year's flagship. We'll have interest meetings in March, April, and May, and our program director, April Garner, will reach out to everybody that has expressed an interest. Thank you, Jared. So at this time, I'd like to introduce our guest speakers today, and we're going to start off with Alisha Hutchens. Alicia is the Chief Operating Officer for Novant Health Forsyth Medical Center and has been with the organization for 13 years. She has extensive experience in the healthcare industry, serving over 20 years with a leadership background that includes supply chain, strategic sourcing, and hospital administration from both an academic medical center and a large integrated not-for-profit organization. Alicia is a proud graduate of the Leadership Winston-Salem class of 2018. Our next guest is Dr. William Satterwhite. Dr. Satterwhite serves as the CEO of Sneez LLC, a health tech company that he helped found in 2016, but he has a long-standing history in healthcare. Prior to his current position, Bill was a practicing healthcare attorney for a number of years before going to medical school and becoming a pediatrician. His journey in healthcare then took him to Wake Forest Baptist Health, where he serves as the Chief Health and Wellness Officer. Our third guest today is Dr. Brian Hiestand. Dr. Hiestand joined the Wake Forest family in 2010. He is board certified in emergency medicine as well as clinical informatics and has served in a number of leadership roles throughout the organization, as well as within the larger Atrium organization. He is currently serving as the co-chair for the Atrium Health Wake Forest Baptist COVID-19 Task Force. Moderating for us today is Ned Erickson. Ned is the Director of Community Engagement for the Greater Winston-Salem market of Novant Health. Prior to taking this role, he founded and directed a not-for-profit called the Winston-Salem Fellows, a professional leadership development program for recent college graduates. He's served on many boards and currently volunteers with Leadership Winston-Salem's Alumni Council, as well as with Healthcare Day Committee for the flagship program. He is a proud graduate of Leadership Winston-Salem's class of 2015. And at this time, I would like to turn it over to Ned to begin our webinar.
Thank you so much, Catherine. It's an honor to be here today. Alicia, it's great to see you. Really appreciate you being here today. Bill, it's great to see you. Go Wildcats. We're having a great season. Brian, it's great to meet you. We have I married into an Ohio State family, so I'm a Buckeye fan, and my wife's a double deacon, so really glad you're here as well. If you wouldn't mind, as we are just getting to know each other, I would love to give each one of you the opportunity to just trace a little bit of your story of where you came from and how you got to where you are now. So, Alicia, do you mind starting us off?
Sure. Can everyone hear me okay? Thumbs up? Yeah, so I'm a proud graduate of Appalachian State University. I actually started my career, which was formerly at Wake Forest Baptist Health, right out of college in supply chain, and then I worked for a stint in nursing administration. Later went back to supply chain, worked in sterile processing, managed sterile processing there, went on to be in contract administration, and then was looking for more experience with a larger healthcare organization that was more integrated with other community facilities. And at the time, Novant had an opportunity for me. And so I transitioned and went to Novant Health as a strategic sourcing manager, negotiating large medical contracts for cardiology, radiology, lab, and multi-million-dollar equipment associated with those needs. Great opportunity for me. From there, I developed a program called New Product Introduction for the Novant Health footprint, and we rolled that out across the entire system, and then took on a broader role as overseeing all of supply chain administration throughout the entire organization. I decided that I wanted to get a little bit closer to the patient, and I wanted an opportunity to work in acute care. And so I set my sights on something very different. At the time, I was actually being published as a supply chain expert and won an award for healthcare contracting nationally. I was also moving into a new role, which would take me out of supply chain, and was working as the Vice President of Professional and Support Services for Novant Health Forsyth Medical Center, where I'm still today. And now I'm proud to say I'm the Chief Operating Officer here on this campus, and just love the work that I do. I see myself as a transformational leader that really works hard every day, keeping the patient at the center of everything that we do and every decision that we make. And I really enjoy motivating large teams of people and leaders to do great things to promote patient care and also help leaders invest in themselves and see professional growth. And I'm really excited to be with you guys today. And I am a proud graduate of Leadership Winston-Salem. Thank you.
You're muted, Ned.
And I think you're muted.
Sorry. Bill, do you mind sharing a little of your story with us?
Sure, be glad to. I have an interesting history in being born at Baptist Hospital a long, long time ago, when my dad was an ear, nose, and throat resident in the 60s. And I think the place they birthed babies then is now the burn unit. So I was born in the burn unit, and grew up here in Winston. Went to Davidson College, then Carolina Law School, then was a lawyer, as you heard. Left that, came to med school here at Wake, and have done pediatrics and some different administrative leadership things, actually first with Novant and then with Wake Forest Baptist, and enjoyed a lot of that time. There's a lot of creative opportunity happening in healthcare right now. And so then I also decided to take the leap from big to small and jump in to a startup that I helped be a part of a number of years ago. And that's housed in Winston Starts right now. It's called Sneez. You can see the banner in the background over my shoulder. So thanks for letting me be here. I definitely do not have a standard career path. So if you or your children need career counseling, do not send them to me.
Thank you so much, Bill. I'm honored that you came today to be with us. Thank you. Brian, do you mind sharing a little of your story with us?
Certainly. I appear to be the transplant here amongst the panel here. Although as a Ohio State grad, I do hold a special place in my heart for App State and what they inflicted upon the University of Michigan that one fateful day. So definitely props there. But so no, I received my undergraduate medical school residency and faculty position at Ohio State University in the first half of my career. I'm emergency medicine trained and was faculty in emergency medicine at Ohio State for 9 years or so. When in 2010, my mentor, who had come down here several years ago to be chair of emergency medicine, he and I met up at one of our national conferences, and he took advantage of a moment of distraction and brought me on down here. I loved what I saw and haven't looked back. It's been a great journey here, joining Winston-Salem and Wake Forest, especially as we've expanded our ability to provide patient care through the region by expanding our network of hospitals and emergency departments that we provide coverage for. I started my career as a researcher in emergency medicine with a focus on cardiovascular emergencies. That led to additional research training in my master's in public health program with a focus on biostatistics and epidemiology. And then that transitioned into a kind of love of all things nerdy and geeky and into the realm of clinical informatics, electronic medical records. How do we leverage technology to deliver care for the patient at scale and as an individual? I think anybody who's worked with an electronic medical record realizes we are far from hitting that ideal, but we're making improvements on a regular basis. Coming here to Winston-Salem, I've had leadership roles at running our observation medicine unit here on the Winston campus. And now one of the medical directors of our regional operations center, which handles patient transfers, bed placement, patient flow throughout our 5 hospital network, as well as handling transfers to our quaternary medical center from regions. Through the COVID pandemic, we've received transfer requests from Oklahoma, as have everybody. I mean, everybody's looking for space, and it's been hard to come by. In addition, I am now the service line leader for emergency medicine for Atrium Health Wake Forest Network, which is the 5 hospital system, also known as Legacy Wake Forest, as we partner with Atrium and align to deliver care throughout a multi-state region. Thank you.
Thank you so much, Brian. I'm a transplant too, so I feel you on that. Well, I was watching the ACC basketball tournament March of 2022, and all of a sudden they just stopped the game mid-game, and my life changed. And I don't know where you were, but I am interested in learning a little bit of, what were you doing in March 2020, and how did this pandemic come into reality for you? What was that experience like? Alicia, why don't you go? We'll go in the circle again.
I think for me in March of 2020, it seems like forever ago, number one. I was just really going through the motions of being a mom and a wife, and carting children back and forth to sport activities, which came to a very quick halt. And then in my professional world, we were trying to tackle patient flow and capacity management. So Brian, I loved your comments on that. And really, that was at the forefront of what we were trying to focus on at Novant, and specifically for the greater Winston market with Forsyth and our community hospitals. And we had been working on flow for quite a while, but we were launching some more sophisticated efforts. And then March of 2020 came, and all that just kind of stopped. And we had to be really nimble. Thankfully, we were very agile organization, and we were able to do that work, but obviously in not the uniform fashion that we had planned to do. And so it was an interesting time, a very somber time for us to see that hit in March of 2020.
Thank you, Alicia. How about you, Bill?
There we go. Yeah, so March of 2020, I was still in my role at Wake Forest Baptist as Chief Health and Wellness Officer. And I really remember where I was sitting on this back screen porch doing some different work. And I think, reading some news or whatever. And I thought, this thing is actually going to hit us. Mm-hmm. And we had already begun having trouble getting face masks for people in the field, and surgical masks. And we would check in, and the supply chain folks would be like, "Oh, we've ordered them. I'm thinking, yeah, from China. China's like falling apart, And that's when I really had this idea of, we're going to have to figure out how we can make some masks in some way, mass produce them to cover the whole city. Otherwise, I can't think of a great way to live life. And from my perspective, there was enough data out there that masks were helpful. It's kind of, masks are a bit like wearing a jacket in the rain. Whether your jacket helps you or not depends a lot on how hard it's raining and what kind of jacket you had. But compared to nothing, something is usually helpful. And so that's what began the Mask the City project that some of y'all probably remember, where in about 30 days time, we went from, concept to contract with Renfro to mass produce all these masks and put them in the city. And so really within weeks, the whole city of Winston had at least one mask available. And again, that was a time when there hardly were any. And that was right when the CDC was beginning to talk about it being helpful. And so it was really this stunning community-wide effort that was amazing. It's probably one of the most amazing 30 days of my life, where 390,000 masks were bought and distributed to pretty much every corner of the city of Winston-Salem, including free ones for those who couldn't buy them. And so that's what I think of when I think about March 2020.
Hey, there's a mythology that you had all these different prototypes on a table, and you're trying to figure everything out. What's the reality?
Yeah, well, that was actually true. And what we were doing is, some of the people on my team happened to be really good at making things. And so, those were kind of cut and sew masks, we would call them cloth masks. And then we got connected with Renfro, and Renfro is a sock manufacturer. So they're like the largest sock manufacturer in America. All their plants are down because, every store is closed. And so we showed them what we had done. They're like, oh, that looks great. We can't make that. Come to Mount Airy and look at the machines that we have, which are these kind of spinning things that spin the socks, right? And so then we had to spend a whole day with them trying to figure out how can we take that equipment and what you've got and turn it into something that would be helpful that you could wear on your face. It was a fascinating time. It was a bit like the movie Apollo 13 a long time ago when they were running out of oxygen and they have to figure out some way with a coffee filter and, some hoses to, change nitrogen into oxygen or whatever. And so it was a fascinating time. So part of that is true. There were lots of things laid out on the table, big conference room. We took it over for just this whole period of time. But at the same time, there was then sliding into, being able to mass produce with a company. And that meant you had to use their stuff. And I mean, they had the capacity to make 500,000 masks a week. It was stunning. And that was when they told me that, I thought, man, we could mask the whole city. And we ought to figure out how to go for that because they can actually do it. And so, they sold several million masks. I don't know how many, but it was that some of the myth is there, but that's the true part too.
Thank you, Bill. How about you, Brian?
Yeah, so by the time March rolled around, we'd already been meeting for some time. We started preparations in December of 2019 when we first started hearing about this coming in China. We had gathered representatives from all aspects of the medical center, including international experts like Dr. Christopher Ohl, and really started thinking about what would this mean. We thought we had a handle on some good first steps. Events quickly outpaced what we thought we had prepared. So by the time March rolled around and the ACC tournament was shut down, I remember that as well. It's like, we knew that we were starting to surf a tsunami that was really going to be a generational in nature. So figuring out, and actually the front end of things was pretty darn easy. It is easy to shut everything down when everybody is rowing in the same direction. And suddenly you can just turn everything off and people are in agreement with that. By far, the harder mission was how do we turn back on safely and in what order? On that first part of the pandemic, we rapidly realized we were short on testing. It didn't exist. We were short on supply chain, on PPE. We were long on people and goodwill. I mean, when you shut down the clinics, you shut down the ORs, you have extra personnel who can help support all the things that you are still ongoing. We developed that expertise. We had a number of supply chain contacts that allowed us to bring in PPE to the medical center and carry on with some of our critical functions. At first, I learned more about HVAC and supply chain than I ever thought I'd need to know as an emergency physician. So air handlers and HEPA filters, and this was all new work to me. And that's what this was a development for a growth. We all grew through this in ways I personally never expected. Thanks.
But you kind of touched on the next question, Brian. Alicia, why don't you share a little bit of, what were the big challenges that you noticed Novant faced right at the beginning of this pandemic, and what you've experienced actually throughout?
I think that undoubtedly the COVID pandemic is leaving a lasting impression on our industry. And I just would say that, really reflecting back on that time period, and even now today, is we still have 70 plus COVID patients in our facility. It's the workforce, and specifically enhancing the team culture and the development of new creative ways to engage in the workforce. And so it's really crucial to take care of the patients during the pandemic and the influx. I think Brian said it earlier, patients as far out as Oklahoma. Kentucky stands out to me for Forsyth Medical Center, but it's also important to understand that you have to treat the whole person, but then also you've got to rally around the shared purpose for the people treating the person during this time, and really understanding what the person needs caring for the patients during the pandemic, what the patient needs, understanding the safety risk, folks being scared. I think that was very challenging, for no doubt across the entire industry. But that's one thing for Novant Health that we kind of put a stake in the ground as it related to not only the patient-centered health, but the team members that were dealing with this, and just the influx of emotions that came with this, and the fear and the long hours, and trying to do what we can to support the community, but supporting our most crucial asset, which was our team members. And so in the early days of the pandemic, I remember that we launched Thriving Together platform to help our team members really flourish and take time through the pandemic to think about themselves. It was kind of a holistic approach of the well-being of our team members. We focused on 5 areas: emotional wellness, human connection, financial and community resources, and then the physical health of the leadership. That was also trying to keep these team members motivated to come to work every day in what at the time felt a very, very concerning and vulnerable environment. So for me, that's what I think about, is I think about the human impact, whether it be from the patient perspective or from the team member perspective at Novant Health. And I'm really proud of how we have continued to handle that throughout this journey.
Thank you, Alicia. I think one of the reasons why we wanted to create this panel was there's been so much talk about how hard COVID has been and how it's changed everything. But, one thing that I've also recognized that this has been a time of new innovation, of adaptations that are just, I remember my wife saying that, more changes happen in 30 days than in the last, I forget, 10 years or something like that in healthcare. So I'm really interested in hearing from each of you about, what have you noticed have been the big adaptations, innovations, that kind of seismic shifts that you've seen in healthcare. And Bill, why don't you go first, and then Brian, and then we'll have Alicia go.
Yeah, so I think the pandemic accelerated a trend that was already happening, which is really pushing care outside the 4 walls of the bricks and mortar. And some of that became much more possible because of things like payments. So people often wondered, why don't doctors do telemedicine visits and phone calls and this and that, as visits? And the answer was because they didn't get paid for doing them. And so, it's hard to be motivated to do a lot of that when Medicare and other insurers won't pay for that, quote, visit, even if it took the same amount of time. And so the good news was, the pandemic created such urgency and need that those doors were blown open to create a pathway for that. And, there's sort of nothing like a crisis to get things moving. And so that's probably one of the biggest trends is taking care that we always had done inside the 4 walls, realizing, well, you don't always have to do it in there. Here's how much can we do outside of there, and let's do as much of that as we can. And so that's a real different thing.
Thank you, Bill.
Yeah, I'm going to agree with Bill. Prior to the pandemic, telehealth was really kind of choked down by CMS policies, such that there were a very limited number of circumstances where CMS recognized telehealth as a viable option. Patients had to be remote, had to have no access whatsoever to other avenues of healthcare. And it's true that is a very good use case for telemedicine. But by what we've seen since is that it is applicable in a wide variety of situations. I think and we're starting to see a resettling of where telemedicine is at its best. When everything shut down, everything moved to virtual, and it was like having a multi-tool, one of those pocket tools. It's not the best screwdriver. It's not the best pair of pliers. It's not the best of this and that, but it's there and you can use it to get through. Now we are figuring out, where does it absolutely make sense that virtual care is the right size for this? That not every patient encounter is best set for telemedicine, but many are. So we are in the final phases of learning, where does that make sense? And we still face uncertainty with this, because right now, third-party payers, the government are still providing financial support for these visits and for the work that we're doing. We need to build a system where the virtual platform is value added, even if everybody decides, okay, we're not going to pay for this anymore. How do we still leverage this to provide the care for the patient in the setting that makes the most sense? The other aspect is operating a healthcare system as a system, not a collection of hospitals all sharing the same stationery, but actually working together as a system. I think we were pretty well positioned. We'd moved in that direction prior to the pandemic. Our operations center really came into its own as we started working through making sure that our region was as well cared for as we could with resources, and distributing our patients to where they needed to be, where they could be cared for. Thank you.
Thank you, Brian.
And then I guess I'll just say, staying on the long lines of the telehealth, I completely agree with my two panelist partners here. You know, really for us, it's just that quicker adoption of new technology. Telehealth, obviously, we went to that route. We started using that. We are continuing to do that. We've been very successful for that. But I think for us, it's even moving that forward. And really, I think it was Brian that stated it's about what your patient needs. And so it's using technology to empower the patients to receive more care, whether it be home health, whether it be virtual visits, you know, whatever it is in regard to innovation, and how quickly we can do it, and how we can use models like artificial intelligence to support and empower clinicians at all levels to really connect with the patient where they are physically, as much as what they need from the clinicians during the time of the pandemic and then beyond. So I'm happy to say, I think because of the pandemic and our nimble structure, we were able to very much in the early days adopt the telehealth opportunity, and we've been very successful for that, and really are continuing to train our staff and scale up our telehealth capabilities, which really are now part of a staple of our healthcare patient-centered delivery model. And so I'm proud of that. I'll also say, in addition to that, I think it's worth noting that the pace of innovation in healthcare is really going to be the legacy of COVID-19. You know, we've capitalized on this rapid evolution of change in the healthcare industry. I think some industries in the past have been quicker to do that than healthcare. And I think that with the pandemic, we can all look back and be proud of how quickly we've been able to adapt and be agile, and whether it be new innovation through technology or other forums, but really making very quick changes to impact the patient that normally changes to systems and innovation may have taken us years to adopt. By going through all of our strategic structures and what we need to accomplish, we've been able to really implement in a matter of days so that we could meet the patients where they are and really support the overall pandemic. So I just think that's one thing I would also add to my takeaway from COVID-19 is just that legacy of innovation in healthcare and the quick ability to adapt seamlessly across not only one facility, but across an entire organization and healthcare industry as a whole. I'm proud of that from a Novant perspective, and also our partners in healthcare, and then the overall industry has done really well with that.
Thank you so much, Alicia. To add on to that, you know, as you think about these innovations, what changes do you foresee continuing? What trends do you see in the future just continuing to become part of our lives post-pandemic?
Is that for me, Ned?
Yeah, Alicia. Yep, yeah, we'll go Alicia, Bill, and Brian.
I think for us, it's more innovative technology. We're seeing the greatest opportunity in artificial intelligence. So it's continuing down that path. I think it can tackle some of our greatest challenges in healthcare. I think it's astounding at what we can do with it. And we're trying to really focus on not only AI support and what it can empower the clinicians to do. We see as an opportunity to reduce burnout with those at the bedside, an opportunity to diagnose patients sooner, to give information with patterns and trends more quickly to administrative teams making decisions. We're already leading AI work nationally with our stroke system. And we were the first in North Carolina to really roll out our partnership with Viz AI into our stroke care program. That's proven very beneficial for us. We've received great results. And when you work through AI and you really implement models and invest in AI, you can really not only help your team members, your clinicians, everyone at the bedside, but it's ultimately a positive result for the patient. And again, it's that patient-centered focused care that we have to keep focused on. So I think that's for us, that's one thing that I think we'll continue to see changing in the future. More innovation in technology, and specifically for us, we see a great opportunity to continue investing in AI.
Alicia. How about you, Bill?
Yeah, I mean, I think all that's true, certainly around technology and where all that's going. I think that, healthcare is still going to struggle with staffing shortages. That was already bad before the pandemic hit, and that just made it worse. I think there's going to be a continued movement of care outside the walls as people have gotten used to it. As I tell folks, before the pandemic, the only thing I ever bought off of Amazon was books before the pandemic. Now I buy everything off Amazon. I buy fencing for my yard off Amazon. I don't actually go anywhere. And I thought, wow, that is a stunning change. And it wasn't because I was really thinking about any of that. I mean, I just bought books off Amazon. I went to the store, the hardware store for something else. Now that's totally changed. And so I think some of that, is going to stay ingrained as people are then saying, so why should I go to the hardware store, or why should I go to the doctor? Why can't we just do it right here? And so part of that is just sort of a mindset change that we're going to have to continue to adapt to, because frankly, our system is set up for the most part for you to come in person. That's sort of how it's all set up. So it's going to be interesting to see how much of that plays out and sticks in those ways. But people have tasted and experienced something different. And so we're going to have to keep that in mind as we design our own systems.
Thank you, Bill. What do you, Brian?
Yeah, I really think that the delivery of care where the patient is via the use of telemedicine technology is here to stay. I think the challenge is integrating that into existing systems of care as to provide the best outcomes. What we've seen from it's almost a generational change. The people who were using telemedicine before, young individuals who had episodic self-limited illnesses, they don't need to interact with a primary care physician. They just have an issue that needs managed right now. As we get telemedicine more conditioned throughout the entire population, you have people who have chronic medical needs who are no longer as satisfied coming into a particular office just to have a discussion about their chronic care. How do you integrate telemedicine into longitudinal primary care? How do you maintain that episodic acute care need? How do you leverage telemedicine so that a patient out in the mountains of in Wilkes County can still get the same quality of care as a patient here on the Winston campus? And that's something we've established with our virtual consult platform. We are delivering specialty care to all our systems, to all our hospitals in our network, so that you don't have to leave your home to, if you're hospitalized locally, you can stay locally with your support network, your people, everybody around you, and still get world-class care. We are utilizing telemedicine after somebody is to get some people out of the hospital as soon as it is safe to do so with our hospitalist at home program. Over 5,000 visits since we've established this, with a countless number of patient days saved. And that's not just a hospital benefit, which I'm not going to lie, it does benefit the hospital to get an empty bed. It benefits the patient to be at home. And we've tracked these metrics that these patients who are followed by the hospitalist at home have a substantially lower readmission rate. They get well and they stay well and they stay at home. Where nobody likes to come into the hospital, even if you're collecting a paycheck. So if you can stay well and stay at home, that's the best outcome for our patients. But I really think that establishing that interface between technology, telemedicine, and systems of care delivery is where the future is going to lie. Thank you.
Thank you, Brian. Yeah, Bill mentioned the Great Resignation, which is sort of a buzzword right now. I don't know. We don't need to talk too much about it. I don't know if you guys have some statistics or figures that could kind of put that into perspective for the challenges that each one of your institutions are facing. I don't know if you have those numbers that could just help us understand the challenges that you're facing from a staffing level. Alicia, do you have something?
I don't know that I have exact numbers to report, but I can comment and say that, and I would hope my partners agree with me. We can talk all day long about the evolution of healthcare and about what's coming in the future and what we've learned from the pandemic. But the Great Resignation is a real concern, and it's about people. And if we have all of these grand ideas about whether it be AI, whether it be other platforms for home health, for virtual visits, we've talked a lot today about telehealth. We've got to have the human connection. And that's where we really need our focus to be. And so that's really going to impact and is impacting all healthcare, and really it's impacting all industries. We're seeing it. I mean, I see it if you try to go anywhere where there's any type of customer service needed, there's a lack of staffing, and that's the bottom line. We need people to do our jobs, but in healthcare, we need people to connect with other people. We need people to be empathetic. We need them to be at the bedside and show compassion. And the only way to do that is to retain your people, whether it be competitive pay, whether it be benefits, whatever you do, but it's got to be about developing a patient-centered and personal-centered focus for your team members, because it's not enough anymore to just have the pay and the benefit. There's got to be more connection there with the needs of, for us, we call our staff at Novant Health team members. And so we've made some bold stance. We really have. Just recently, I'll share, we made a $40 million investment back into our team members. We launched that a couple of weeks ago for anybody at the assistant director level and below. So that's hitting our front lines. And for us, that's an investment to 40 hours equivalent payout of PTO or PTO. And so you may think, well, that's a great opportunity. They get a choice there. The choice is what's intentional behind it. It's about understanding that our team members today have different needs than our team members pre-pandemic, and even their needs from many years ago. So it's about meeting them where they are, giving them a choice that they can make, that's what's best for their unit, their family unit outside of Novant Health. And I think really learning about how to motivate people and keep them a part of your team going forward has been incredibly challenging, because healthcare workers went through a lot and they still are. And so it's really about connecting with that human piece. And we can have the most wonderful technology in the world, and maybe healthcare will get there one day. I certainly hope we do. It can be great benefit to our patients. But if we do not take time to really invest in the people component behind the technology, we will fail. And I am proud that at Novant, we are really making a stance to get it right with our people. It's not perfect, but we have made a stake in the ground, and we really want to connect back to the human component of what our team members need. Thank you.
Thank you, Alicia. Brian, do you have any thoughts on
Sure.
the Great Resignation?
Right. And so we talk about this like it's a big monolithic, one flavor, one size fits all. And it's not. And it's not quite, you see one resignation, you've seen one resignation. I mean, there's definitely some themes. But as stated, this is going throughout all the workforce, and it's a global phenomenon. And it really is. I've seen pieces in Forbes that a lot of it's being outside of healthcare, at least a lot of it's being driven by early retirements and people figuring that enough is enough. Let's go ahead and get out of the workforce. But I think a lot of it is also due to the fact that anybody who's read Daniel Pink, one of the key satisfiers for your job is having a sense of purpose. Healthcare brings that kind of ingrained, but it sometimes gets hard to recognize that sense of purpose when infrastructure and the realities of what we're dealing with on a day-to-day make it difficult to feel that you're making a difference. And I think that the struggles that the COVID pandemic have brought forward, there's a limit to what people have in terms how many times can you go to that well and not feel that you've made a difference in your patient lives. Having that degree of resilience, I mean, that's something we were long on people. We were long on resilience at the beginning of this. We were short on everything else. But as the hourglass is flipped, now we've got tests, we've got PPE, we've got expertise in taking care of COVID, we've got vaccines. We're running dry on the resilience, and that's really. I mean, people are recognizing that their labor has value across all aspects. But it's not just leaving for benefits and money and things like that. It's how do you make sure that you are valued on every level, having the autonomy to do your work, being asked to do what you are a master of, and having that sense of purpose in your work. So I think that a lot of places outside of healthcare, that's what we're seeing. I mean, nobody wants to work in a service job where you're abused by the general public on a day-to-day basis when there's no sense of purpose when you have alternatives. Healthcare is a different beast, and we certainly are feeling this on all levels in terms of the Great Resignation, but it's changing with every wave. Why people are leaving healthcare. Initially, there was a lot of fear. I mean, I'm not going to stick around where I'm going to get COVID. And then that changed over time to, I have nothing further. The well is dry. I've got nothing left to give. So, and keeping up, trying to predict and support and provide that sense of renewal and being able to refresh the resilience. That's a task for sure.
I did want to get to a couple questions that were sent earlier and sent today. So there's one question. Thank you, Brian, for that answer. One question is, in a study by Helo, which I don't, Heallo, or is it Helio? I need my glasses. It says this, more than half of primary providers agree their patients' health worsened due to inaccessible or delayed care. And the question is, what is the local healthcare's response to create increased access to care? I'm guessing that has to do with like delayed surgeries and things of that nature. But is that something that you've experienced, and how have you addressed it? Brian, why don't you go first? Bill, I don't know if you have an answer to that, but then we can go to Alicia.
Sure. So, I mean, certainly we experienced that when, again, the great shutdown in April 2020, where clinics were closed, med school was closed, ORs were closed, as we were trying to find our way forward in an area of vast ignorance. We didn't know what this virus would do, how it was transmitted, how we could protect. And then as things moved through, we've got improved access to both primary and specialty care. But then, especially with Omicron, it proved that we're as individually vulnerable to this virus as anyone. And so staff illness really started taking its toll in terms of accessibility. supply chain is better, but still randomly great. Sterile surgical gloves. Who saw that shortage coming? So here and there are still pockets of things that will crop up and limit care, but it's better than it was for sure. Is it back to where it ideal state? I wouldn't say that it is. But as people come back to work after recovering from their Omicron and the vaccines have really, it is amazing the difference in recovery rates if somebody does get sick from those who were vaccinated and those who were not. So a widespread vaccination program, which all of our institutions engaged in, really kind of blunted as the impact that could have had. But staffing shortages still persist. We're working on getting through that so that we have people available, as Alicia said, at the bedside to deliver care. So it's not so much the systems as the ability to shoulder the load right now, and that's getting better. It's not fixed, but it's getting better. But it will last for the next several years to come. We can only train so many personnel to step up. We are seeing shortages in our paramedics, in our nurses, in our NAs. I've had emergency physicians just leave medicine altogether and go do something else. And so there's a lot of us still showing up, but we're going to ask for a little patience because there's a lot more work to be done. Thanks.
Yeah, Alicia, do you have?
Yeah, I completely agree with Brian's comments. I think I would just also add, it's important to also note that, access to care means different things to different people. And so with the pandemic, that's no different. I think it's going to be incredibly hard to quantify, the impact that COVID has had on the community, especially as it relates to access. And I will say, and Brian touched on this a little bit, our doors were open. So yes, I think access was a challenge, but there's multiple reasons for that. It wasn't because we all closed our doors. We did not close our doors. We tried to find unique ways to leave our doors open. I know I can only speak for Novant. I mean, yes, surgery was impacted, but urgent and emergent continued. We developed special teams built with physicians and administrators and schedulers to look and see what is critical and how do we quantify that and how do we make those great decisions to make sure that, again, the patient's at the center of what we're doing, while also keeping the patient safe, because we didn't know what we didn't know, and the team members are safe. And so access during different surges was challenging, but I'm actually proud of the work of myself and the partners that we have in the healthcare industry of how we continue to maintain and provide viable care that those that need it most. There's no single solution to opening up access and providing it, because again, it means different things to different people from different socioeconomic backgrounds. And I think we have to keep that at the top of mind as we're finding our way out of this pandemic. It is not fixed. Staffing is still a challenge. It is getting better. And then I think going back to our comments earlier, I think we can also put innovation into this, as we've talked a lot about artificial intelligence, telemedicine, virtual visits, home health. What are we doing to think outside the box for our team members at the bedside? And if there's a shortage of those, how do we do that work differently? And that's hands-on work. I think of a bedside nurse, for example. And so how do we still give a bedside nurse the tools that he or she needs to do the job, understanding there's less of them? And what about the support people around them? So, for us, and talking about trying to keep the doors open and providing great care to people, it's pulling, who can support CNA work? What can food and nutrition do outside of the box when they're delivering trays within their realm of responsibility that still meets state mandate regulatory requirements, by the way? Keep in mind that the governance behind that is still in place. I see Brian smiling. He knows what I'm talking about there. That's a big deal. So what can EVS do? What can environmental services do above and beyond what they were doing pre-pandemic to take work off the frontline clinical team at the bedside? And so that is the unique innovation we have to think about from a human perspective, that has gotten us out of a lot of difficult situations, and we've gotten we've demonstrated a lot of ways to think broadly about that. And I think that there's going to have to be more discussion about that and realize the wins that we gained from that through situations with access and through the height of the pandemic. And to Brian's point, we continue to deal with this shortage that's very real.
Yeah, and just to dovetail a little bit off of that, I mean, keeping that list of critical and emergent surgeries going. We also developed a team to run through that list, but I saw in the chat a discussion about mental health. You want to talk about wearing on you, deciding who goes first with such a limited resource, with such ill individuals. That took a toll like nobody's business on the teams who had to work through that decision making. And it wasn't just surgery. We saw this with multiple areas. When you have 4 pages of patients waiting to transfer into your healthcare system, and you know that you can't take them all, there's a moral sense of not justified, but it's a moral sense of failure that you couldn't help more, and that strained our teams more than anything else.
Yeah, and I'll add to that too, Brian. I'm glad you mentioned that the mental health component. We think about the COVID impact of that to the patients and to the communities that we were served. I mean, there's higher rates of substance abuse, of depression, anxiety, suicidal ideation, but there's also that effect on the people providing the care. So I agree, mental health is a topic on its own that needs a lot more time than what we have today. But that's a huge impact to not only the people providing the care, but also the patients that we continue to see.
Thank you for pointing that out. We're gonna bump up against the hour. It's gone by so fast. I'd love for each of you to maybe take a minute and think about, what have your institutions, you personally have learned through this pandemic that is going to better prepare you for the next one. Heaven forbid it won't be anytime soon. But what are some learnings that you're taking forward with you, and maybe what's something hopeful that you're taking from this as you're thinking about the future, maybe personally even, or as an organization? Bill, why don't you go first, Brian, and then Alicia.
Yeah, I mean, I think one of the things that has hit me most during the pandemic is just the importance of personal relationships, and who are you willing to put yourself at risk for, to be with and figure that out versus not. And so I think that particularly got highlighted for me over the last couple of years. I would say sort of leaning forward into, what I look forward to that is good is, I just think there's been such a great acceleration of change in a good direction for how healthcare thinks about what it does, and pathways that have been opened that have almost been sort of a buildup behind a dam for all kinds of reasons. And so I think that that's a very hopeful thing, that there's now enough movement and current to keep a lot of that in place so that things can be different. It's easy in medicine for historical reasons, financial reasons, regulatory reasons, just to kind of do the same old thing. And that kind of got blown open. And so I'm very hopeful about what that'll look like.
No. Brian?
I think a lot of what I've learned, besides how much trust I can put in my team, which is all of it, is how to navigate rapid change and information saturation. And that's one of the things that we've developed so much knowledge in such a short time that it's actually disconcerted a lot of the general public. They got to see what happens when science occurs in real time. Usually science and knowledge translation occurs in the background, and a concept doesn't come out to the general public knowledge until it's relatively well-formed, well-vetted. We were seeing study after study, things come to the front, and this one changed a little bit, and that one changed a little bit, and this one was completely off base, and this was saying something completely different, and that's how science happens. But it's never happened in the public eye like this before. And it was messy, and it really brokered a lot of mistrust. And it's like, wait, you were just saying something different. Well, because we knew something different. So learning how to manage and those changes around communication and the cadence. I mean, let's put aside the willful stream of misinformation and disinformation that's out there. There's just a lot of, I mean, the drinking from a fire hose is the appropriate metaphor here. So how to make sure that you've got to build trust in the communication streams with leveraging your experts and having them be able to communicate and meet people where they are to get that information out, to build deserved trust in both the systems as well as some of the, I mean, vaccination is one of the key aspects. We didn't have to mandate a lot, but we had to mandate some. That being said, by engaging our experts, by leading from the front, we were able to get, we were showing that vaccination was the right thing to do when people were, when the people leading the response were the first ones rolling up their sleeves. So how to lead from the front, how to manage communication, how to work with the pace of change are skills that I think we've all acquired that will help us, knock on wood. Hopefully the next surge doesn't come through. I'd like to be done. Lord, I'd like to be done. But for the next one, we're ready.
Alicia, final word from you?
Yeah, great comments from my panelist partners, and I agree with them wholeheartedly. For me, two things stick out. It's being completely committed to your people. And then in addition to that, it's being innovative in your approach of thinking, your action, all the way through execution. And so for the people part, it's about investing in them, and investing is not just pay. Investing in them is resources, is training. Now it's about, okay, we've proven we can be flexible, we're agile, but it's giving them that professional development so that if we ever face this again, we know that they are ready and they can do it. But now it becomes part of the culture of who we are. We can't flip this facility on a dime. We can flip this organization on a dime. We've shown that we can do that. And it's time to take back and understand, you know, with your people, you know, I've learned who I want to go to battle with. I mean, leaders have stepped up, frontline team members have stepped up, and I would go to battle with this team any day of the week. I am completely 100% confident in the work that they do. And I'm glad that I'm here to partner with them. And now it's about reminding them of that great work that they did and empowering them to take it to the next level for the next unknown that comes down the pipe, and really challenging them to be the best version of themselves while we take ownership of investing back into who they are, meeting them where they are, and giving them full confidence in this new hybrid workforce that we're in, with those that are working remote, those that are working inside the facilities, and just making sure that we take the steps to make sure that everyone feels connected and supported regardless of their role, regardless of their location. We need them now more than ever, and they're completely critical to everything that we do. And I would say that to the ones that's left, but mostly the ones that are here that have rolled up their sleeves and decided to really continue through with this journey, because those are the people that you want taking care of your loved ones. The people that are here, that are in the walls of Novant Health, Atrium Baptist, that's the people that you want at the bedside. And so it's committing complete support with those people. And then the innovative thought behind that, I think that for me, and being a leader in a leadership role, the best leaders think differently and they do things differently. And for me, I think about having an entrepreneurial mindset as we move forward, which is not something that you typically see in healthcare. In fact, we don't like to go in uncharted waters, and we like to, you know, historically, we sometimes are known as the industry that takes too long to make change happen. And now we've realized that rapid change is who we are. It's who we are for survival and for taking care of you. And we're going to continue to be committed to that. And so we've got to continue on with that. We don't go backward. We have to move forward. Think like an entrepreneurial, think like, you know, the next innovation of care, what we can do, and continuing to move forward. And so those are the two things I would leave you with that are most important to me.
Thank you, Alicia. Bill, Brian, we could definitely do another hour. Wish we had it. Catherine, I'm going to pass it back to you if you want to close this out today. Thank you again, panelists.
Thank you.
Thank you, Ned. Thank you to our Alumni Council, and thank you especially to our speakers who have joined us today, not just for your time today in answering questions that our Leadership Winston-Salem family has about healthcare and innovations and what we've been facing over the past 2 years, but thank you for your time, your dedication, and the energy that you've poured into our healthcare system and therefore into our community at a time when it was shifting sands, to be sure, every single day. So on behalf of Leadership Winston-Salem, our alumni, our family, and our community, thank you very much. We'd like to thank everybody that joined us today for being a part of the Leaders and Lunch webinar. We'll be having another one in March, so keep your eyes peeled for those questions that